Welcome back to The Explainer. We're diving straight into part 5 of our 6-part series on bilateral vestibulopathy. Today, we're tackling management, VRT, pharmacology, and ototoxin prevention. Since you're dealing with these complex cases in clinic, we've got a lot of high-yield ground to cover. Let's get right into it.
As senior clinicians, you already know the harsh reality here. Spontaneous recovery in BVP is incredibly rare. So our entire therapeutic focus has to shift. We're aiming to prevent further loss, maximize central compensation, and, absolutely crucially, reduce that fall risk. Our management is going to be etiology-directed and rehab-centered. But, before we even try to build the patient back up, we have to establish a strict do-no-harm baseline. Interestingly enough, one of the absolute most common management errors we see today involves prescribing a very specific class of medications.
Okay, let's dive into this clinical roadmap. We're covering 4 main pillars today. First, why we absolutely must avoid vestibular suppressants. Second, cause-directed medical management. Third, vestibular rehabilitation therapy. And finally, a look at some emerging tech with vestibular implants.
Pillar number 1, avoid vestibular suppressants. They are strictly contraindicated.
The literature is crystal clear on this one. Vestibular suppressants are contraindicated in bilateral vestibulopathy. Why? Because they literally further suppress whatever residual vestibular function is left and totally impair central compensation. Now, we've all been there. A patient walks into your clinic severely unsteady, maybe dealing with debilitating oscillopsia, and your natural clinical reflex is to prescribe something to just calm their system down, right? But with BVP, prescribing these meds is actively working against the sensory substitution that your patient desperately needs just to stay upright.
So let's look at the usual suspects. If your BVP patient comes in taking prochlorperazine, maclizine, dimenhydrinate, any benzodiazepines or antihistamines for their dizziness, you've got to hit the brakes. These need to be ceased immediately. Doing a full review of their current prescriptions and systematically pulling them off these suppressants is literally step 1. Because frankly, you simply cannot rehabilitate a vestibular system that you're actively suppressing with pharmacology.
Moving right along to our second pillar, cause-directed medical management.
Now, we have to be upfront here. We don't have a magic pill. There's no restorative pharmacotherapy to regenerate vestibular hair cells in humans just yet. But we absolutely can and must intervene based on the underlying cause to stop further damage. For instance, with aminoglycoside toxicity, you've got to instantly cease or substitute that agent because once that damage sets in, it's permanent. No going back. If it's autoimmune inner ear disease, you're hitting them with a high-dose prednisolone trial first, then transitioning to steroid-sparing agents like methotrexate. For NF2, we're looking at surgical or radiosurgical routes. For canvas syndrome and idiopathic VVPV, it's all about supportive management, VRT, and fall prevention. Oh, and a quick reminder, beta-histine has 0 evidence of efficacy for established VVPV. Don't bother with it.
Speaking of stopping damage, we have to stay hypervigilant about major preventable ototoxic offenders. We're talking aminoglycides like gentamicin, which is a huge risk in NICU or renal failure settings, chemo agents like cisplatin, and even occupational exposure to industrial solvents. But here's the kicker. High-dose loop diuretics can massively potentiate aminoglycide toxicity if they're co-prescribed. It's like pouring gasoline on a fire. Strict monitoring and swapping out these offenders whenever the oncological or infectious disease goals allow is absolutely your best defense against permanent vestibular loss.
And we can't ignore the massive psychological toll this takes. Living with chronic imbalance and oscillopsia is exhausting. If your patient develops anxiety or PPPD, persistent postural perceptual dizziness, you treat that anxiety with low-dose SSRIs, not suppressants. It's been shown that SSRIs, think sertraline or escitalopram, actually improve balance confidence and lower vestibular anxiety, all without messing with that vital central compensation. Pair that with some targeted cognitive behavioral therapy to tackle avoidance behaviors, and you've got a fantastic evidence-based strategy.
Which brings us to pillar number 3, vestibular rehabilitation therapy, or VRT. As clinicians, we really have to flip the script here. Standard VRT versus BVP VRT are 2 totally different ballgames. In unilateral hypofunction, you're heavily focused on central habituation and adaptation, right? You're recalibrating the system using that intact side. But with bilateral vestibulopathy, well, adaptation is pretty much irrelevant when both sides are offline. Instead, the focus has to shift entirely towards sensory substitution and dialing up those non-vestibular cues to 11.
We can really break this down into 3 core therapeutic targets. Step 1 is maximizing that sensory substitution,
We are literally retraining the brain to rely heavily on visual and proprioceptive inputs. Step 2 is gaze stabilization. We want to push whatever tiny bit of residual VOR function might still be hanging around and really optimize those predictive pursuit strategies. And step 3 is the progressive balance and gait challenge. We're talking dynamic, real-world balance training here. Get them standing on foam, walking on uneven ground, or using treadmill perturbations to safely but intensely challenge those postural reflexes.
Now, while we're doing all this rehab, we have to aggressively stress fall prevention. This is absolutely critical. In BVP, the fall risk isn't just a little higher, it's 2 to 4 times higher than in age-matched controls. That means a terrifyingly high risk of hip and Coles fractures. A bad fall can cause secondary morbidity that completely strips these patients of their independence. So environmental strategies are non-negotiable. Adequate nocturnal lighting? Mandatory, because they rely so much on vision. You might need to prescribe weighted walking frames. And if standard VRT isn't cutting it, definitely look into Vibra tactile feedback devices. The ones that translate motion signals right into tactile stimulation on the trunk or tongue. It's wild tech, but it works.
And speaking of wild tech, let's jump into our final pillar, emerging tech, specifically vestibular implants.
This is easily the most exciting development on the horizon. Modeled right after cochlear implant technology, a vestibular implant is a neuroprosthetic that detects angular head velocity and fires patterned electrical pulses directly to the ampullary nerves. The goal? Effectively restoring the VOR. The proof of concept work here, especially out of the Geneva group, is just incredible. They're seeing measurable restoration of eye movements and a real reduction in oscillopsia, even in patients who've been living with severe bilateral hypofunction for over 20 years. That's a total game changer.
We're also keeping a very close eye on the biological frontier, gene therapy. It's still in the pipeline, but the efforts to actually reactivate hair cell regeneration using ATO1 gene delivery and WNT pathway agonism are showing some serious promise in mammalian models. For patients with specific genetic etiologies, like the COCH mutation in DFNA9, these therapies could theoretically offer true biological restoration down the line. It's a phenomenally exciting space that could completely rewrite how we view this diagnosis.
So, as we wrap up this explainer, I want to leave you with something to chew on. If vestibular implants follow the same explosive regulatory and clinical trajectory that cochlear implants did, are we looking at a future where surgical neural prosthetics are just the standard of care for complete bilateral areflexia? I think it's highly likely. Next time, in the 6th and final explainer of our series, we'll be tackling prognosis by etiology subtype, digging into some controversies and looking closer at the future of BVP management. Until then, visit AustralianDizzinessClinics.com for the full literature review and all the clinical resources you need. See you in Part 6.